Hi, dear friends. Today, our topic is blood. Blood. It is a beautiful topic. I'll try to summarize the most beautiful and essential issues regarding blood. We cannot talk too much about blood, especially if we don't remember the bone marrow. The bone marrow, I will try to show a flat bone and remind us that the flat bones, our flat bones of the skull, or even the spine, the ribs, the pelvis are the ones they contain largest amount of bone marrow. The long bones only mostly in the epiphysis. For example, if we try to draw here a flat bone, you'll have to remember that it has an outer compact bone and also an inner one. And in the center, we have cancellous bone. Well, if the bone is being decalcified, you will remember that it will be mostly looking eosinophilic. Perhaps we can use this color to highlight the compact bone on the outer and the inner surfaces, and maybe, he also over here, and just maybe over here. Now we know that the cancellous bone that is in the center has many anastomosing bony trabeculae, which may be after the calcification looking something like this. In other words, we have almost like a sponge-like tissue having trabeculae of bone that is going to be the site of the bone marrow. Just put it briefly. And the bone marrow, if you cut a bone, you would find out that it is pretty vascular and pretty cellular. You would probably have to find many vascular or many cellular spaces that are filled with cellular elements and obviously fat. Perhaps we can also give it a little bit of a blue, because these are not totally like that. Okay, if we remember that fat is an important component of our bone marrow, I mean, it's not part of the bone marrow, but it is there, and it is in elderly persons, you will get more and more fat, and in a 50 years old person, it will be pretty much 50-50 fat and bone marrow. So we'll here put a little bit of feel a little bit of adipose tissue to remind us. Well, the bone marrow has many sinuses that, once the cells are formed, are mature enough, they are released into the circulation. And for example, we will take any vein of the body. For example, let's say if you take a vein from the arm, you can stretch up your arm and get a sample of blood. You have many of you have probably donated blood and got some blood tests, and you get the experience. And usually, well, you will get something like this. A syringe of blood, or several tubes of blood that will be for examination. Now, the syringe may be placed in different tubes with anticoagulant, or not, depending on the circumstance. Let's place right away the tubes that we will use. 1 and 2 and 3. Okay, if we have anticoagulated blood and we place it in one of these tubes, we notice that it just is a single color, red, and the red color depends on the heme groups of the hemoglobin. Okay, and at this moment, you could get a drop of blood and try to make a peripheral blood smear. And that is done like this. You have, for example, a glass slide, and you deposit a drop of blood, and you may use, for example, another glass slide to draw this blood into the glass slide. That is something like this, obviously. Voila, you have a peripheral blood smear. Very nice, and if you put it to the microscope right away, it will look red, but you will not see much. You need to stain it. So you need a stain which is actually a Romanowski type of stain, uses methylene blue and eosin, and it's called the right Giemsa, or something similar. Okay, now when you look at the cells, and you see that maybe the majority of the cells in the smear are red blood cells, and here and there you see occasional white blood cells. Now, let's remember something, that obviously in a tube of blood, most of the cells are the red blood cells, but there is a little tiny area on the surface called the buffy coat that has the white cells and the platelets. And I guess it's a good moment to maybe share with you the fact that in the past, when there is a leukemia, this area, and sometimes, occasionally today, this area may actually become white and thick. In other words, leukemic cells are going to be on the top, and we're going to have a situation called leukemia. And leukemia comes from the Greek leukos, which is white, and hemos, which is blood. In other words, the leukemia implies the fact that we have white blood. That's not very common, fortunately, but occasionally the number of leukemic cells is very, very high. Okay, now what happens if we centrifuge this tube, this tube with blood? Obviously, the level will be the same, and you're going to get about this percentage of red blood cells and white blood cells. In other words, we find out that the really largest amount that we have in the blood is water with proteins and salts and many hormones and many substances. And this fluid, which is kind of yellowish, is called plasma. We'll call it right here plasma. Now, but there's another possibility, and that's the reason I put a third tube here, is the fact that you may draw blood, put it on a tube, and do not add any anticoagulant. What is going to happen is that the blood will clot. That's what you would imagine. And obviously the clot is a little bit irregular and will release a clear fluid that is similar to plasma, but we do not call plasma, we call it serum. Serum has essentially the same components of plasma, but it doesn't have more the coagulation factors, fibrinogen, fibrin, etc. So that's what we have normally in blood. Okay, now, without further ado, we're going to talk a little bit about the cells of the blood. I'll try to be practical and direct, so not to give you too many facts. Let's start with the red blood cells. Red blood cells are the most abundant cells in the body. Some people calculate in the 25 trillion, pretty much their number. So anyway, red blood cells are rounded, which most cells are, and have a clear area without a nucleus. You know that. Of course, you have seen many times pictures of red blood cells, and essentially we will make it a little bit something like this. Not only does the red cell doesn't have any nucleus, but it doesn't have any organelles, which is amazing for a cell that is so essential, so important. Anyway, when you look at the red blood cell from one side, you would see that it has this peculiar biconcave appearance. So now you would probably, some people may wonder, why is this kind of a funny looking appearance? Well, it's important because the surface of diffusion of gases is increased about almost 30%. And also the deformability of these cells increases quite. So these cells can squeeze through small places, like in the spleen or in some capillaries that have some tissue debris, for example, and go through. Now, you would say, you know, I don't like it. It would be better to have a cell that is just rounded. And actually, yeah, there are diseases like hereditary spherocytosis in which the red blood is rounded, but those red blood cells kind of explode like balloons in the tissues because they don't squeeze enough in those capillaries. Now, what else can we say about many things about red blood cells? Perhaps one of the things is like the remarkably stable size, about 7 microns, which is almost like a micro ruler in your microscope that lets you tell what are the size of the other cells. Of course, there's variation. A few more things about red blood cells. You could say so many things that red blood cells, all the antigens of the blood groups are on the membrane. And that is the ABO group, the RH groups, and all the other groups are in the membrane. So for blood banking, it is very, very important. I will say something more about, how does the red cell survive without having any organelles or nucleus? That's a good question. If you don't have actually the red blood cell takes glucose and metabolizes it in an anaerobic fashion. And so it keeps its shape and function. A red blood cell will live about 4 months, 120 days, and then will be replaced. A good thing is there's so many things I have to talk about the red blood cell, but perhaps I would say something more about the hemoglobin. You have many molecules of hemoglobin here, and are formed by 4 alpha and beta chains, 2 alphas and 2 betas, And they have a heme group in the center which harbors the oxygen. Now, everything is well when it goes well, but when there's a mutation in one of these chains in different places, we have problems. For example, you are familiar with a particular type of red cell that has this shape instead of having a biconcave shape, and that is the sickle cell. Sickle cell disease. And there's only one amino acid substitution in the beta chain, and the 7th amino acid, and that's enough to cause so much trouble, which we know. Though the hemoglobinopathies are a field by itself, so I won't even dare to touch, to go any further. I'll just put some markers here. Now, I'm going to talk about, before about that, some of the red blood cells, and something I was going to forget, are essentially identical, although a little bit larger, and have little stippling of, and that's simply residual organelles that have not been removed from the red blood cell. And this is the reticulocyte. The reticulocyte means that this is an immature red blood cell, and in a couple of days it's going to be, those organelles are going to be removed, and the cell will mature. But if the patient has too many reticulocytes, means that the bone marrow is releasing more blood because there may be some blood loss elsewhere. Okay. Now I want to talk about the white blood cells. I'm going to try to summarize them in an easy fashion. I want to talk about the neutrophil, the eosinophil, and the basophil. Those are the granulocytes because they have granules. But before going in any, mentioning more about the granules, let's talk about the nucleus. And you know that the neutrophil has several lobes, so it's the same nucleus that has several lobes. And I'll have to put a name about it. It's a neutrophil. Neutrophil. Because they call it neutrophil because the granules would not stain in any fashion. Although there are granules, they are not easily seen. And their cytoplasm is mostly pink. I would say pink in color. They are larger than a red blood cell. Not too much, but they are larger. And let's go for the another one, which is going to be the both the eosinophil and the basophil. Both have almost like sunglasses type of nuclei. In other words, bilobed nuclei. And when it comes to their granules, and I'll have to put here just to remind you, this would be the eosinophil, and this will be the basophil. Okay, why would we call a cell an eosinophil? Obviously, because it will stain with eosin. That's a pretty good answer. And the granules are remarkable for being red. And this cell has a tons of red granules. So the eosinophil is a cell stained with bright red granules that almost obscure the nuclei. Now, what about the basophil? The basophil obviously has affinity for basophilic granule, in this case is methylene blue, from the Romanowski stain, and we're going to have many granules that are purplish are actually blue, and they have that. So I'm talking about all the granulocytes in one step because it's easier to compare them, and you don't have to be going back and forth. Now the neutrophil is the most abundant white blood cell. It's about maybe 50 to 75%. In other words, about every 2 to 3 cells, white blood cells, is a neutrophil. It is a lot compared to the other white blood cells. Eos and basophils are very scant. You will probably get about them, let's say, about 3% of eosinophils and even less than 1% of basophils. So to see a basophil is not very common. Now, what are their functions? You probably know them already. Neutrophils leave the blood, enter the tissues immediately, and fight infections. They are able to move. They're able to phagocytize and destroy bacteria. For example, they be present in an appendicitis, in an abscess, in many other situations like that. What about the eosins? Eosins, you see them if you have an allergy like asthma, or if you are infected with a parasite, for example. Parasitic infections, they may be 20, 30%. They are really sometimes very, very high. And the basophils, they're usually not very commonly increased, but the basophils are associated mostly with anaphylactic reactions. Now since they are very similar to the mast cell of the tissues, people thought that it would be a basophil. The mast cell would be simply a basophil that went to the tissues, but this has not been proven. There's granules names for these granules, and I'm going to let you to go into your books if you have to memorize some of them. I don't think that is very practical at this moment. I will go directly to the next white blood cell, which is the largest. I'll try to make it like that, and has a kidney shaped. So the other cell types are about between over 10 microns up to 15, but this one is largest, and it is about 20 microns. It reaches 20 microns. The cytoplasm of the neutrophil is pretty smooth looking. It doesn't show too many granules. It's almost like grayish blue. And maybe the nucleus might be a little bit more dense, but it has this appearance of loose chromatin. Sorry. I'll try to more intensive. Now, monocytes are more abundant than basophils and eosinophils, but they're about in the number of about 5% of the white blood cells, between 3 to 8% perhaps we could say. Now, monocytes are extremely important, and they are similar in function to the neutrophils, because they leave the blood, enter the tissues, and phagocytize tissue even with greater appetite than the neutrophil. Including in the tissues, they get to be a macrophage, and they get to be a histiocytes, and the histiocytes may form a multinucleated giant cell that maybe even phagocytize pieces of suture. They're so phagocytic. I'm going to try to fit here another cell, which is relatively more abundant, the second most abundant of the white cells. And this is actually the nucleus of that cell, which is the smallest of all the white blood cells. And it goes like this. It is a lymphocyte. Lymphocytes are about 25%, around 25% of the white blood cells. They are second in number to the neutrophils, and they are in size about 9 microns, which is a little bit larger than an erythrocyte, but obviously larger forms, activated forms are also present, but that's it. Now the Cinderella of all these cells, I would put it right here, which is not a white cell, but it is a platelet. The platelet doesn't have a nucleus, yes, but it has all the organelles, including mitochondria, that you will need. I drew it about this size because it is very small, about 3 microns. And it doesn't seem like it would be very important, but yes, it is important, and we depend on the platelets to survive. I'm going to pretty much give you a little bit of a diagram to see how the platelets work, but only in a very simplified fashion. If we have a little vessel, for example, looking from the inside, and there is a little rupture of a vessel, it is the hemostatic system is designed to keep all the blood and the red blood cells inside the vessel, so the platelets quickly mobilize in this area and form what we call a platelet plug. So they actually block the defect in the vessel, but there's one problem. We need to stabilize that platelet plug. And that problem is solved because we have I'll use a different color, we have a meshwork of fibrin that is going to, almost like ropes around rocks, block and put together all these platelets. Now the fibrin comes from a protein in the blood called fibrinogen, which is produced in the liver. And that fibrin is transformed into that fibrinogen is transformed into fibrin, which keeps together the platelets, right? That is essentially, in order to activate the fibrinogen into fibrin, you need a cascade of coagulation. But essentially, we are going to keep a couple of peptides in the fibrinogen molecule and allow it to polymerize here. So that's enough for the time being regarding that. I know you may be tired, and I'm going to take a glass of water. We're going to say a few words without getting into too much detail, because at this moment you don't really need too much detail about the bone marrow. Now, all these bones can be, you can put a needle through them, and I can probably make it more. You can put a needle to the bone, with a syringe and something like that, and you can aspirate significant amounts of bone marrow. This is kind of not marking too well. Now, it's kind of painful. I haven't had it myself, but I've done it, performed it myself. It's painful. It may be done under anesthesia. And what you get is a jelly-like material, which is the bone marrow. That may put it into a plate and smeared into glass slides, into different glass slides, more than one usually, one of them, and then they are going to are going to put a portion of that aspirate here and then smear it in this direction. Now you have obviously you have to stain it with the right Giemsa. This is not looking too well. Let me do it like that. Now, when you look at the blood smear, bone marrow smear is different from a blood smear. This is more smooth. Here you have some particles of bone or tissue, and there is a whole host of cells that are intermixed. That almost looks like a carnival of cells. And you have to, they are all the different cell lines are intermixed, so you have to be able to identify each line, each stage, and maybe count them and study them. Now, at the same time that you do your bone marrow aspiration, you can do the bone marrow biopsy. In other words, a needle put through the same bone, which, by the way, usually we use the posterior iliac crest, which is the best bone that is accessible. We can use in the children the tibia, for example, but that is what we do. Now, when we get a bone marrow core, let me put it here, we get the core of bone with trabecula in between, and with bone marrow in different spaces. Obviously, this bone marrow core will have to be decalcified, fixed and decalcified, and then sections will be taken, and the hematologist or the pathologist will examine these slides, which I'm going to try to find us like that. Okay, that way you study the bone marrow. Now, we're going to give us a little bit of a history of the blood cells. That means that they all come from pluripotent or unipotent cells. What does it mean? In other words, blastic cells that have not committed into any direction, but they get committed into one or more directions. Let me explain you guys what I mean. A blastic cell, when you look at an aspirate, you look at a blast, and the blast is like a lymphocyte, and has usually a big nucleus. And the chromatin looks blastic. It's difficult to explain how it looks, but it looks very soft. It looks like this. This is a blast that may belong to one or other category, and usually has one or more or three nucleoli. These are the great grandfathers of the blood cells, essentially the pluripotent or unipotent cells. So let's start with where we're going to use the pluripotent cell. I'll try it like that. I just write here pluri, and remind pluripotent stem cell. Obviously, there's a lot that we talk about the stem cells. Stem cells, yes. These are usually the cells that we want to have when we have a bone marrow transplant. The pluripotent stem cells differentiates into 4 different types of four cells. One for the red blood cells, one for the granulocytic and monocytic, which have a single, one for the lymphocytic, for the lymphocytes, and one for the megakaryocytes. The unipotent cell will be for the megakaryocytes here, mega, for the lymphocytes, for the monocytes, for the granulocytes, and in this case will be for the red blood cells, RBCs, which is actually unipotent cells. These are all unipotent cells. They go a little stage. I will have use a different marker now. They go one step beyond and differentiate into proerithroblast cells, which this one will be a proerythroblast, a myeloblast. I'll have to try to make a little bit a better job. Myeloblast, a monoblast, a lymphoblast, and a meiocardiblast. Now, if we start thinking about the red blood cells, you're going to have to be a bit confused with the numbers. We have the names are a bit confusing, but essentially what happens with the maturation of the red blood cells is quite simple. I'm going to, actually what happens, I use a different marker, that the red cells, these cells are going to get smaller, the nucleus gets smaller, and finally the nucleus is expelled with all the reticulum, endoplasmic reticulum and all the organelles, etc., etc. Now the cell at the beginning, the cell begins to be very basophilic. And since the cell is producing more and more and more protein, it's going to get more and more and more eosin, because the hemoglobin is, the globin part of the hemoglobin is a protein, and is going to stain red. So this cell is going to have a situation of a changing color from blue to red, and from big to small. And what happens to the nucleus? The nucleus becomes almost more and more concentrated and leaves. Now, we have the situation that sometimes we call it this a basophilic erythroblast, or a polychromatophilic erythroblast, or orthochromatic erythroblast. Those are names that are used still, but the only thing what they mean is that the cytoplasm and all the other changes take place in this manner. So regarding the changes of the granulocytic series, we should take them pretty much as a single cell, in a single fashion, should I say. And they go from being a promyelocyte, a myelocyte, and a metamyelocyte. And what is the difference between the promyelocyte, myelocyte, and metamyelocyte? Not very marked, but then, for example, here we have azurophilic granules at the beginning, and we have more specific granules, either red or blue or neutral, in the myelocytic series. And then in the metamyelocyte, we have changes of the nucleus actually, which becomes, let me see, like this. Pretty much in the promyelocyte, the nucleus is somewhat eccentric. In the myelocyte, the nucleus tends to be central. And the metamyelocyte is this way. Now, the eosinophil myelocyte or metamyelocytes are going to be stuck with granules, even also the basophils. So we're different to tell different stages. But The important thing is that the nucleus is with the appearance of granules, and the nucleus becomes more kidney shaped or sausage shaped. And before we get into a neutrophil, we usually get cells that, before being polysegmented, they have only a single stab form, like a stick. This is the stab form, which is more or less like a reticulocyte. It's an immature neutrophil that is going to be twisted. The nucleus is going to be like twisted and form and mature up to have about 4 to 5 lobules. This is the stab form, which is immature. And this is pretty much the maturation over here. Now, regarding the monocytes, it's more simple. We have a pro-monocyte, essentially, and from the monoblast, and the nucleus, it's almost like a monocyte, but a little bit more immature, may have nucleoli, the chromatin may be somewhat different, but then it goes out in that direction. Now, the lymphocyte, well, it goes into another stage called prolymphocyte, and which almost looks like a lymphocyte, but may have nucleoli, may have a more blastic appearance, more immature appearance, and then this prolymphocyte turns into that. Now we'll say a few words regarding the megakaryocytic series, which is interesting in the sense that, let me put it this way, the cell that is going to be rise to the platelets is is the greatest cell in the bone marrow that has a polylobated nucleus. Let's try to make it, the nucleus being not multinucleated but polylobated, and has the cytoplasm, it may be a little bit, has the appearance of certain divisions, and it will give rise to the platelets. Now, of course, right now you guys know how it happens. It's not that this megakaryocyte, which is about 80 microns in size, it's like a big, huge cell in the bone marrow, will not shrink. It will just fragment. The cytoplasm fragments into one to about 5,000 platelets, and they go to the periphery. Then the nucleus of the megakaryocyte is phagocytized by the macrophages in the bone marrow. Now, there's one thing that I want to mention. I hope I didn't get you lost in this very brief explanation. But I'll mention to you guys that the bone marrow, the bones and the bone marrow appear later in embryonic development, but the needs of blood vessels and circulation appear earlier. So who makes blood before the bone marrow is formed? That is a good question. And it is the yolk sac. Yolk sac is something that you probably have to take a peek. It's like a saccular structure adjacent to the umbilicus. It has many functions. One of them is to form blood cells. And obviously, if the yolk sac doesn't form blood cells, nobody else will. After a while, the tissues start to get formed, and the liver and the spleen and the lymph nodes get formed, and then take the load of making blood. For example, if in a patient somebody gets for example, a situation where the bone marrow cannot produce any blood, the liver may produce, or the spleen may start produce in an adult patient blood. It will be extramedullary hematopoiesis. That's what it's called. But I hope you got something out of it, and I'll be seeing you next time. Take care.